was telling my family that I was coming to do this patient conference where many of my own patients would be in the audience coming to sort of listen to us talk about the management of kidney cancer, and my son piped up and said, "Dad, isn't it a little weird being in a room full of people that you've seen naked?" Anyway, welcome. So I'm going to give two lectures, hopefully not put you to sleep. One is on the management of locally advanced kidney cancer, and then the other is the role of surgery in metastatic kidney cancer. So what we know is that stage is probably the most important predictor of outcome in patients with kidney cancer. The more advanced the stage, the higher the risk that the tumor is spread and become incurable. This is the staging system that we currently use in 2012. This is the AJCC staging system where we stage the tumor, we assess regional lymph nodes, and then look for evidence of metastatic disease, and then we come up with a stage that looks like this. Now, people get hung up on stage, stage 1, stage 4, and so forth, but this is really what it describes. It allows doctors to communicate about patients and talk the same language with regards to how advanced their tumor is. And as you can see, with increasing stage, there is a more advanced tumor, either locally advanced or metastatic. Then I'd like to go over some definitions just so that we're all on the same page. Adjuvant therapy. Adjuvant therapy means to take some form of therapy, be it chemo, radiation, vaccine, whatever, after complete surgical tumor resection, with the idea of trying to decrease the risk of recurrence. The benefit of this approach is that the patient's already had surgery before getting any additional therapy, but the downside is that many of those patients may already have been cured by the surgery and they're getting a treatment that they don't really need. Neoadjuvant therapy means to take some form of therapy, be it chemo, radiation, whatever, prior to surgery, with the idea that it may allow the primary tumor to decrease in size and also decrease the risk of recurrence. The benefit is that it may allow the primary tumor to shrink and make surgery easier, but the downside to that approach is that the therapy may be ineffective and may not inhibit metastasis, and the primary tumor may not regress, but in fact progress during therapy. The reality, currently effective adjuvant and neoadjuvant therapy does not exist for kidney cancer in the year 2012, and any therapy must be developed in the context of a clinical trial that includes a placebo. The only way we're going to make advances is by testing what we do now with any advance in the future, and what we do now, as I said, is nothing. And patients have a hard time, I think, with placebo trials, but you need to know, if you participate in such a trial, that the treatment you're getting may not be good, and the placebo or no treatment arm may in fact not be so bad. So who should get these therapies? Well, why not just give them to everyone? Well, anyone who's taken any of the therapies that currently exist today know that toxicity can be significant, and you're treating a significant number of people who really don't need that therapy. Well, if nothing works, then why not just let's not give it to anybody? Well, we're never going to make advances that way. And so it's important that we continue to do clinical research and participate in clinical trials that focus on patients who are at the highest risk for relapse. So maybe we should only give it to those patients who are high risk. Well, there comes the problem. How do we define risk? And how high is high? It's not really clear. So this is the landscape for adjuvant therapy in 2012. A variety of different trials have been performed. Many of you in this room have probably participated. They've included use of local therapy such as radiation, embolization, energy ablation. Variety of different hormonal therapies have been used. Immunotherapy with interferon and interleukin-2 have been used in the adjuvant setting. There have been a variety of different vaccine preparations that have been tested, and we actually even did a phase 3 trial with thalidomide here at MD Anderson. And to date, not one of these therapies has shown benefit in the adjuvant setting to decrease risk of recurrence. And in fact, many of the patients who were on the treatment arm did worse than the patients who were not treated. So what about targeted therapy? That's the great unknown. Where do things stand with targeted therapy in the adjuvant setting? Well, we now know that since 2006, and you'll be hearing a lot more about this later on today from some of our other speakers, but since 2006, 7 new treatments have been approved for the treatment of kidney cancer. It's been a revolution. And to be honest, many of you in this room have benefited from that advance, otherwise would not be with us today. So how do we use these agents in the context of adjuvant therapy? Well, there are a variety of different clinical trials that are either recently completed accrual or are currently ongoing. This is one called the ARISER trial. This used an antibody called G250, which was against carbonic anhydrase 9, and patients were randomized to either antibody versus placebo. This trial completed accrual many years ago, in fact, and we're still awaiting results, which leads me to believe that it's probably going to be a negative trial. However, this agent has recently shown promise as a potential PET scan for kidney cancer. So, in other words, you can use this as an imaging agent where patients are infused with the antibody linked to iodine 125, and this will show up on X-rays. So you can actually potentially detect micrometastatic disease that's not visible on CT scan. And this is currently actually undergoing the FDA approval process. This was the ASSURE trial. We conducted this at MD Anderson. This is a randomized trial between Sunitinib, Sorafenib versus placebo. Patients underwent surgery and then were treated with these agents for 1 year. This trial completed accrual last September, and we're now waiting for patients, or waiting for the trial to mature to see whether these agents have any benefit in the adjuvant setting. One thing we did learn from this trial, however, is that tolerance for the toxicities associated with adjuvant therapy is not the same in the adjuvant setting as it is in the metastatic setting. In this trial, 41% of patients stopped therapy early, not because their disease recurred or not because they finished, but because of toxicity. And I think it really amounts to an individual assessment of risk. You know, if I tell you you have a 20% risk of your cancer coming back versus a, say, 70% chance of your cancer coming back, and you're miserable on this therapy, all of a sudden 20% doesn't look so bad. And my concern about this is that at the end of the day, when this trial matures, and it's negative, say, is it negative because these agents don't work, or is it negative because patients couldn't tolerate the therapy and there were too many patients that stopped therapy early or had dose reductions, what have you? I'm afraid it's not going to be interpretable. This is the S-TRAC trial. This is a trial that's sponsored by Pfizer. This, again, recently completed accrual. It's randomized between Sunitinib versus placebo for 1 year. Estimated that the results will come out in 2017. And that's the other problem with these trials, is that the agents that we're testing now, are they even going to be relevant in 2017? No one knows. This is the SOURCE trial. This is ongoing primarily in Europe, where patients are randomized to 3 years of Sorafenib versus 1 year of Sorafenib versus placebo. There's been real problems accruing to this trial. We can't even keep metastatic patients on Sorafenib for 3 years, never mind adjuvant patients. This is a trial that's currently ongoing in the United States. This is sponsored by GlaxoSmithKline. This is called the PROTECT trial. Patients are randomized to 1 year of Pazopanib versus placebo. And this is predominantly for patients with clear cell histology. This is currently open at MD Anderson. And then this is the EVEREST trial. This is sponsored by SWOG, or the Southwest Oncology Group. This is going on around the United States, where patients are randomized to 1 year placebo versus 1 year of everolimus. So you can see that clinical research is actively ongoing to try and identify whether or not these agents work in the adjuvant setting, but it's going to take more time before we understand from these trials whether or not these agents are applicable in that setting, or whether or not, like the other agents that have been tried, they remain ineffective. One other concept that we're currently testing at MD Anderson that I'll talk about a little bit more in my next talk is neoadjuvant therapy. This is a trial that looks at neoadjuvant Axitinib therapy. Some of you in the audience have been on this trial, where patients receive 3 months of Axitinib and then undergo nephrectomy. I'd really like to applaud the patients that participated in this trial. I'd like to sort of give you an idea of how this went the first time we enrolled a patient. Patient comes in with a tumor that's curative with surgery, and we say to him, hey, we'd like to give you this agent. We have no idea if it'll work. In fact, your tumor may grow and metastasize while you're getting this agent. And in fact, if we took you to surgery tomorrow, we could cure you. What do you say? It was really amazing. The first patient that enrolled in this trial, very brave. But since we've been able to demonstrate that this agent has activity, enrollment has picked up significantly. So I'd like to talk a bit about management of more advanced disease. And this includes patients who present with tumor thrombi and management of nodal metastases, adjacent organ invasion, and then finally renal fossa recurrence. So first, venous tumor thrombi. So this is one of the biggest operations that I do. About 15% of patients present with venous thrombus from their kidney cancer, and these can be huge operations. These thrombi can go all the way up into the heart, where we have to put patients on bypass, open up their chest, and get a cardiovascular surgeon to stop their heart so that we can take the thrombus out. We use transesophageal echocardiography to monitor the thrombus during the surgery to look for evidence that the thrombus breaks, to make sure that the thrombus doesn't break off. This is a series that we recently published at MD Anderson, 605 patients who had venous involvement. Median age was 60, follow-up of a little more than 2 years. 45% of the patients had no evidence of metastatic disease. Conversely, 55% of patients obviously had metastatic disease at the time of therapy. So you can see, again, that importance of stage. The more advanced the stage, the higher the risk of metastatic disease. These are big operations. Our median blood loss was almost 1 liter. Operative time was a little more than 3 hours. Patients stay in the hospital about 6 days. You can see our complication rate. But I think the important note is even with venous involvement up to the heart, in the absence of metastatic disease, the median survival is over 5 years. So these patients can be cured with surgery alone. But unfortunately, once they demonstrate evidence of metastatic disease, survival drops off dramatically. So we looked at a variety of different parameters. I won't bore you with all the details, but looked at a variety of parameters to look to see what predicted survival in these patients. And this is what we found. Basically, those patients who had clear cell histology actually had a more favorable prognosis than patients who had non-clear cell histology. Those patients who had advanced grade, the presence of sarcomatoid dedifferentiation, invasion of the perinephric fat, nodal metastases, or obviously distant metastases, all of those features were associated with an adverse outcome in patients with venous tumor thrombus involvement. Interestingly, what we saw in our series, which is not something that is out there in the literature, is that the height of the thrombus didn't seem to matter. So in other words, if it was only in the renal vein versus in the inferior vena cava, didn't seem to matter in terms of outcome, and that's at odds actually with the literature that's out there. Only when the tumor went all the way up to the heart, that red line at the bottom, that was when we saw a decrease in survival in patients who had surgery. And our series is in concert with other series that are out there in the literature with regards to survival. And that is, in the absence of metastatic disease, patients can have a long-term durable survival, about 60% 5-year disease-free survival. One of the things we also noticed from our series that had at least me wake up was that the concept of the vein margin. 270 patients who had no evidence of metastatic disease, almost 20% had cancer present at the margin of resection. When we're resecting the vena cava, we're obviously limited in how much we can take unless we're going to do a reconstruction of the vena cava, which can be quite difficult and fraught with complications. But what we noted was that those patients who did have a positive margin, meaning that there was tumor sitting at the margin where we cut the vein, were associated with a higher level tumor thrombus and a higher Fuhrman grade. And those patients had a worse outcome, not surprisingly. And so now, when we do this surgery, we actually send the margin for a frozen section to be sure there's no cancer at the margin. And if there is cancer at the margin, we usually will reconstruct the vena cava to try and eliminate all the cancer. This is another series that's out there in the literature. As I said, our series is a bit at odds with this series. Here they noted that those patients who only had renal vein involvement had a significantly better outcome than those patients who had IVC involvement. So there are some data out there that suggests that the height of the tumor thrombus is somehow related to outcome, but that's not what we're seeing in our patients. And in this series, inferior vena cava wall invasion, tumor size, fat invasion, nodal metastases, and distant metastases all were associated with an adverse outcome in patients with venous tumor thrombi. One devastating complication of venous tumor thrombi that I just wanted to touch on is this so-called concept of BUDD-CHIARI syndrome. BUDD and Chiari were two physicians that identified this syndrome. And basically what happens is that the thrombus gets so big that it actually plugs up the vena cava and plugs up venous outflow from the liver. And patients present with abdominal pain, ascites, which is basically fluid in the abdomen, an enlarged liver, lower extremity edema, and their liver function tests are all abnormal. And this is a picture of one that presented to us. When we take these patients to the, or if we take these patients to the operating room, the mortality rate is about 80%. So we no longer take these patients to the operating room because there's such a high mortality rate associated with this. Instead, what we do is we embolize the tumor. Embolize means to just cut off blood flow to the tumor. And those patients that then regress, we will take to surgery, and many of them do well. This is just a recent series of patients. It's not a very common presentation, but we had 6 patients, 2 of whom were without evidence of disease after 3 years using this approach. Let me move on to nodal disease. This is one of the only randomized trials that has been done in urology where patients with localized kidney cancer were randomized to either undergo a node dissection or not undergo a node dissection to look to see if a node dissection improved outcome. And as you can see from this graph, or from this table, patients that had node dissections did no better than patients who did not have node dissections. And many have used this in the urology community to say that patients who have kidney cancer do not need to undergo a node dissection if they have no metastatic disease. In a more recent update on this, with more mature follow-up, again, same story. Those patients who had a node dissection did no better than those patients who did not have a node dissection. But one of the things about this trial that troubles me and troubles many in the urologic community is the significant percentage of patients who had very low-stage disease. So again, it gets all to this concept of risk. If you study what you're doing in a low-risk population where the frequency of the event is so small, you're never going to see a difference. And the problem with this trial is that they needed to focus on more advanced stage disease to really see if node dissection makes a difference in the treatment of patients with kidney cancer. The group at Mayo did some very elegant studies where they showed us where the positive nodes are. So now that when we go in and do a node dissection on a patient with a locally advanced tumor, we have a very defined area where we know the highest likelihood of metastatic disease will occur. Because if we just took out all the nodes, the complications would be enormous. So we really need to be directed in where we go looking for nodes and remove them in this fashion. The group from UCLA did a retrospective study, and what they noted was that if you did not have enlarged nodes, then it didn't matter whether you took them out or not. Again, the same story as the EORTC trial, but again, critics of this argue that it represents low-stage disease. But one of the interesting things that they noted was that in patients who did have positive nodes, that if you took those nodes out, they did significantly better, indicating that even in the absence of systemic treatment, surgical resection could influence the biology of the tumor. The group from Mayo Clinic identified features that predicted for positive nodes. These include high nuclear grade, the presence of sarcomatoid histology, large tumors or more advanced tumors, and the presence of tumor necrosis. And what they did was they assessed the primary tumor when it came out of the patient, and if it had more than 2 of these features, the risk of having nodal disease was significantly high, that they triggered a node dissection. So now they're using this prospectively to see if these features do in fact allow us to predict who has the highest likelihood of positive nodes and therefore should undergo a node dissection. This was a study that was done some years back, but intrigued me, and that is in patients who have even metastatic disease and have positive nodes. So they have, so let's say mets to the lung, but also positive nodes. Those patients do significantly worse with regards to their prognosis than patients who don't have positive nodes, suggesting just some adverse biology that's associated with node involvement. And they also noted that if they could resect the nodes, again, in the presence of metastatic disease, they did significantly better than those patients where the nodes were left in place. This is a study out of UCLA that basically demonstrates the same thing, that those patients who have positive nodes, even in the setting of distant metastases, do worse than patients who don't have positive nodes. We recently looked at our experience in patients with metastatic kidney cancer with positive nodes, and this is limited to clear cell histology. And we had 55 patients who had positive nodes compared to 322 that did not. And what we noted was, again, the same story, that patients who have positive nodes do worse than those do not. But you can also see that those patients who undergo a lymph node dissection, even in the setting of metastatic disease, did significantly better, almost a doubling in their survival compared to patients who did not. And so nowadays, when patients present, even with metastatic disease, for cytoreductive nephrectomy, if they do have positive nodes, we aggressively resect them because I think it significantly impacts their outcome and their ability to go on to get treatment. What about patients who don't have metastatic disease but just have positive nodes? How do those patients do? Well, we recently looked at our series of patients who had positive nodes in the absence of metastatic disease and wanted to assess what factors predicted outcome. So out of 3,201 nephrectomies, we identified 2,521 that didn't have metastatic disease, and of those, 68 had positive nodes. And what we found, surprisingly, again, now positive nodes mean the tumor has left the kidney and it's metastasized. But even in that setting, surgery patients do pretty well. Their overall survival rate was 37%. You might say, wow, that's pretty low. But that's just with surgery alone. And the disease-specific survival was 39% at 5 years. When these patients recur, they usually recur early, usually within the first year. And you can see that here. But more than a third of patients actually recurred greater than 1 year out. When patients do recur after this surgery, they usually recur in multiple places with metastatic disease. And then we wanted to look at factors that predicted for outcome in these patients. So these are the demographics. The vast majority of these patients had good performance status. They had symptoms that were local, meaning just confined to the primary tumor. And the overwhelming majority of these patients had clinically positive nodes. So this is not microscopic disease. This is big nodes that you can see on CT scan. And what we noted, interestingly, in terms of predictors of overall survival, those patients who had papillary histology had a significantly better outcome than patients who had clear cell histology. And those patients who only had one node involved had significantly better outcome than those patients who had more than one node involved. When we looked at time to recurrence, again, papillary histology seemed to be a predictor that patients would do well. So patients who have papillary histology and positive nodes, we will aggressively resect them. And this is the multivariate analysis, which predicts for overall survival. And you can see papillary histology, the number of nodes positive, the presence of sarcomatoid histology, and performance status all predicted outcome. But with regards to time to recurrence, only the number of nodes positive and tumor grade were predictive of outcome in these patients. What about adjuvant therapy in these patients? Well, I already told you adjuvant therapy doesn't work, but in this particular group, 5 patients got adjuvant therapy, but of those, 4 recurred. The important thing is that 85% of these patients had good performance status at 3 months. So what does that say? That means that we can do an aggressive surgical resection and patients bounce back pretty quickly, so that if they need to go on to get additional treatment, they can do so even after this very large surgery. So these are the features that we predict outcome: papillary histology, number of nodes positive, sarcomatoid features, and ECOG performance status. A little bit about adjacent organ invasion. So most times when kidney cancer grows, it pushes things away. So it rarely invades the liver, rarely invades the colon and things like that. And when it does, it's usually a really bad sign. And that's shown here. PT4 are patients who have locally advanced disease with adjacent organ invasion. You can see those patients do the worst. One of the challenges as a surgeon when patients present with a CAT scan that suggests there's adjacent organ invasion is trying to determine whether it truly exists. Because if we could identify those patients who did truly have adjacent organ invasion, we might refer them for systemic treatment with one of the targeted agents before doing surgery. So we had 53 patients here who had evidence on their CAT scan of adjacent organ invasion. 30 had no metastatic disease, 23 had metastatic disease. And the interesting thing was that 38% of those patients did not have adjacent organ invasion. So what does that tell you? That tells you that CAT scans and MRIs are not the be-all and end-all in terms of surgical planning. And that in fact, 40% of the time we were wrong. And if we had doomed those patients to not undergo surgery, but in fact go on to get systemic treatment, makes me wonder what their outcome would have been. And this graph just demonstrates that patients who have adjacent organ invasion do bad. In the absence of metastatic disease, the median survival was 2 years. And in the presence of metastatic disease, patients were dead within 6 months. These are big operations. median blood loss of 2.5 liters. I'd like to point out that that 15-liter blood loss was not my case. We do see major complications, but the mortality rate is acceptable, so we can get patients through the surgery, but it is a big surgery. And at the end of the day, the factors that predicted outcome in this group really were those patients who did not have true adjacent organ invasion. And then again, that feature that pops up that predicts outcome, presence of node metastasis. And then I'll finish up with renal fossa recurrence. Am I doing on time? Okay. Renal fossa recurrence. So what that means is after the kidney's been removed and the patient's recovered, the tumor grows back in the same place where the kidney was. This was a retrospective study we did at MD Anderson some years ago, looking at 16 patients who had locally recurrent kidney cancer. 8 of the patients received neoadjuvant treatment, and 7 received additional adjuvant treatment after surgery. And what we found was that 50% of patients the group that received neoadjuvant therapy, 50% were NED versus the surgery alone group, only 25, suggesting that a combination approach to these patients with some form of therapy plus surgery was better than surgery alone. And this is a study out of the Mayo Clinic that basically shows the same thing, that if patients receive systemic therapy plus surgery, they did significantly better than if they only received systemic therapy alone. We recently published our experience on patients who have renal fossa recurrence. We identified 54 patients who presented with a local recurrence. 69% of these patients received some form of perioperative systemic therapy, and all under one surgical resection. Again, you can see that this is a relatively aggressive form of kidney cancer. The recurrence-free survival was about a year. But with aggressive surgical resection, these patients can live a long time. The median cancer-specific survival was more than 5 years. So we tried to identify which features predicted outcome, and what we noted was that those patients who have a tumor size less than 5 centimeters, the ability to get a negative margin, meaning to remove the entire tumor with surgery, the absence of sarcomatoid features, a normal LDH, which is a blood test that we get, and a normal alkaline phosphatase, another blood test that we get, all of these features predicted outcome. And so nowadays, when someone presents with a local renal fossa recurrence, we look at these features to determine whether or not they are a good candidate for surgery or whether we should refer them to our medical oncology colleagues for additional treatment. So in summary, aggressive surgical resection, when feasible, still remains the best treatment for kidney cancer. The role of targeted therapy agents in the adjuvant and neoadjuvant setting is unknown and really should be protocol-driven. The management of locally advanced disease remains a surgical challenge, but when done properly by experienced surgeons, can be associated with excellent outcomes. Thank you very much for your attention. I appreciate it.